Okay, I think we'll make a start. Welcome everybody. I'm Dr. Anna Bolton. I'm the Associate Director of the VCCC, and I'm welcoming people that are here in person today, as well as those who have tuned in online. For those of you who are meeting in person, I'd like to acknowledge the lands that we are meeting on here today, the traditional owners of those lands being those of the Wurundjeri people of the Kulin Nation. Pay my respect to their elders past, present and emerging. The Victorian Comprehensive Cancer Centre, as you well know, is a powerful alliance of 10 successful Victorian organisations committed to cancer control. And we have a really niche role in facilitating the integration of innovative service, research and education programs in Victoria across multiple institutions. And in that unique role, we like to share intelligence with other institutions that have a similar role worldwide. And today we're very fortunate to have with us Mr. Rami Rahal, who is the Executive Director of a group called CPAC, or the Canadian Partnership Against Cancer. CPAC is an independent organisation funded by the federal government in Canada, and it's there to progress national priorities on cancer control across the country. Rami leads a portfolio that includes system performance, data integration and research, and he's a self-confessed data geek, which we all love. So please join me in welcoming Rami. Thank you.
Thank you so much, Anna, for that kind welcome. It's great to be here with you today in beautiful Melbourne. I love the city. I was here in 2014, and it is my favorite city in Australia. Anybody here from Sydney? Sorry, but it is my favorite. And I want to thank Dr. MacArthur for being such a great host, and Catherine, who's not here today, been amazingly hospitable. Thanks for the invitation. And so let's proceed. So yes, I'm with the Canadian Partnership Against Cancer. And is there a trick to this? So I'm here to talk to you about how we used performance measurement to advance policy and planning in the Canadian context, essentially to do evaluations and ensure that we are achieving our overall objectives. So I'll start off by saying a little bit about Canada, and then talk about some frameworks for evaluation and then lessons learned from Canadian efforts. First, a little bit about Canada. Everybody's seen this kind of typical picture of our Canadian Rockies. Canada is a big country like Australia. From the east coast to the west coast is about 7,000 kilometers, which is sort of more than halfway from Vancouver to Melbourne. Like Australia, Canada is quite urbanized. So about 80% of the population live in cities like Toronto, Calgary, and my favorite, St. John's, Newfoundland, very colorful. But we do have a large proportion of our population that live in remote rural communities, which makes it a challenge, just like it is here. Actually, about 100,000 Canadians live in communities that are not reachable by road. We have Indigenous populations that need a lot of support, immigrants, and homeless people. And we have significant issues in terms of access to care. So we have issues in underscreening and overscreening. This is a picture of the underscreening, colorectal cancer screening, which is, we're trying to roll it out and get better uptake across the country. This is a picture of thyroid cancer screening, which we have over-diagnosis, over-treatment of, leading to increased cases. So we continue to challenge with that balance between doing more of what needs to be done and less of what should not be done. We have significant challenge with wait times, and that all presents a big barrier for us to address. So Canada has a few more people than Australia, 37 million. We have about 200,000 cancer cases per year. Like is the case here, we have increasing and aging population. The number of cancer cases is expected to go up by 40% in the next 15 years. Huge challenge in terms of the pressure that puts on the cancer control system So you have the rising costs of care, diagnostics and treatments, and you have the increasing demand because of the aging population. So again, similar to the challenges in many high-income countries. The top cancers in Canada are, to a large extent, similar to what they are in Australia. For men, prostate, colorectal, lung, and bladder. For women, breast, lung, colorectal, and uterus. You'll see here the difference. Melanoma is not huge. It's about 6 or 7, it's about 2 to 3% of our total cases. It's a trade-off. When we don't have enough sun, we have less melanoma. So Canada has 10 provinces and 3 territories, and the burden of cancer is not equally distributed across the country. We have a west to east gradient. In the west, we have a lot of this is British Columbia, a lot of very active people. Smoking rates are low. People eat healthy, eat well. You see the rates here under 500 per 100,000, and it gets progressively worse as you get to the East Coast, where people like to have fun, eat, don't exercise much, drink a lot, and the rates are well over 600 cases per 100,000. And we do have a challenge in the north as well, where a lot of our Indigenous communities live. So the Canadian Partnership Against Cancer was set up to advance the cancer plan for the country. So in Canada, like in Australia, the health system is provincially run, but the federal government does help advance some priorities. These are the goals: fewer people developing cancer, more people surviving cancer, and a better quality of life for people with cancer and beyond. So these should not be any surprising. I think we have very similar objectives overall. It's really how we break them down and how we start to evaluate what is happening underneath those strategic goals that allows us to assess how close we are getting to achieving these long-term objectives. So we have a number of themes that help drive our work at the Canadian Partnership Against Cancer, and these themes really determine how we assess progress. And we need to ensure that all of them are balanced in determining our progress towards outcomes. So quality is the first theme. Are we delivering effective evidence-based care? Equity is a very important topic. Are we narrowing the gap in cancer outcomes between at-risk populations and others? Seamlessness or patient-centeredness. This is a term that we use to describe a system that's organized around the needs of patients and the public, and not organized around the needs of providers and clinicians. And sustainability. Are we providing cancer control services in a way that balances resource use and patient benefits? So when we are evaluating our impact, we need to make sure that we are scoring high on those 4 themes. So we cannot have quality at the expense of equity or at the expense of sustainability and seamlessness. So all 4 need to be constantly part of our evaluation approach. So CPAC works with a lot of partners to advance the strategy for cancer control. We are a little cog in the wheel. The cancer system in Canada costs about $6.5 billion a year, of which we contribute $50 million, which is a drop in the bucket. But we use that $50 million in areas where we can make the most progress on those challenging, sort of more intractable problems that require the whole country to work together in order to achieve progress. But still, we work with a large number of partners at the provincial, territorial level, the national level, patient advocacy groups. We work closely with research groups, clinician groups, professional associations, and so on. And together, we essentially help identify priorities across the cancer continuum, and then those areas of focus that we want to achieve progress on. And measurement is essentially at the heart of the process. It's at the beginning to identify gaps, and it's at the end to evaluate progress to address those gaps. So these are just some examples, because I've been talking about our organization as a kind of abstract concept of a federal agency in a provincially run system. Some of the work we've done is we've helped launch a large population cohort study of about 300,000 Canadians who were recruited with their full information on health status, health behaviors, with biosamples. And that's an important resource for research into the causes of cancer, into genomics, and other key questions that we have in cancer control, similar to some other longitudinal cohorts in other countries like UK Biobank and so on. We do a lot of work with our Indigenous communities. We've developed cancer plans specific to First Nations, is what we call our Native communities, Inuit in the north, and Métis communities, all addressed in a distinct, specific way through individual cancer plans. We've launched screening programs. The colorectal cancer screening program was launched by CPAC across the country. An example of something that is done more effectively working together. We've launched pilots for lung cancer screening, and we're looking at expanding those and potentially looking at rollout of lung cancer screening across the country. We do a lot of data collection and standardizing data for measurement. That's something that makes sense, again, at a national level. Strategies and supports around prevention, including supporting prevention policies. We're implementing a national smoking cessation program for cancer patients, given the very strong evidence about improvements in the outcomes of treatment for patients who stop smoking. And we fund clinical trial infrastructure across the country. So just to give you a sense of some of the work that is done, which would be relevant when we talk about how to evaluate the impact of that work. Speaking of which, just sort of the approach that we follow, which really is how we advance our work at the Canadian Partnership. So I talked about measurement being at the beginning and at the end. So everything that we do because we've identified and measured a specific gap, a disparity between where we want to be and where we are currently. So we start off with the evidence through measurement. We are called a partnership, so we do a lot of engagement. Then we take the data and we engage with the various stakeholders and partners, decision makers, to help sort of identify what are the barriers that need to be addressed to achieve our objectives. We co-develop a strategy to improve care and to address the barriers. So everything is done, again, working very closely with our partners on the ground, who include oncologists, clinicians, researchers, planners, policymakers, and so on. And then we implement the strategy to address the gap. Again, we do that. And here we do it with kind of the coalition of the willing. So we don't necessarily apply the strategy across the country. We look at provinces who are interested in moving ahead on that gap. There might be 2 or 3 of them. And so we work with them to implement that strategy on the small scale. And then we do an evaluation of the impact of that strategy or intervention. And then if we feel that the conditions are right, the evaluation is positive, the results are promising, then we would do scale up and spread across the country. So that's very much the standardized process of how we do our work. There's nothing revolutionary here. This is the typical sort of quality improvement cycle. It's just our variation of that. So I'm going to talk a little bit about the measurement and engagement piece, and then a little bit about the co-development and implementation, just to give you a sense of how we use the data to drive progress. And so we've had 10 years of reporting, and there's lessons that I'm going to go through. Measurement with purpose. Don't measure just to measure. So measurement has to be driven by objectives. Focus on priorities. There's no point in measuring everything under the sun. You need to look at what's important. Know your target audience. The types of how you communicate your indicators, your quality measures, how you disseminate them should be driven by who your target audience is. If it's clinicians, it's one approach. If it's policymakers, government, it's another. So it's a very important consideration to understand who you're trying to convince to make changes in decision-making and behavior, and to tailor the message to the target audience. Data quality issues are always come up early, and they need to be addressed quickly because they compromise the whole process. So if measurement is at the heart of evaluation, you need to ensure that you have the right data. And if you don't, that has to be fixed quickly before you move on. So the point of evaluation is to drive action. And so having very clear calls to action are very important, and they should be matched with each indicator should have clearly identified levers of control, what has to happen to affect change in that indicator, and don't make your audience guess. It needs to be that the action needs to be tied to the measure. Again, there's no point in measuring if you're not going to make changes. And so knowledge mobilization, knowledge translation efforts should be attached to each measurement and evaluation effort to actually affect that change that you're trying to make happen. The patient perspective should be embedded in all measurement. At the end of the day, everything we're doing is for the benefit of patients, for their quality of life. And so the patient perspective should not be a token ingredient. It should be at the heart of the process, and it should be the lens through which all measurement and evaluation happens. Even if you're looking at concordance with adjuvant chemotherapy guidelines, it should still be presented from the patient's perspective. And I'll give you a couple of examples of how that's done. And then, the indicators in an evaluation should be used to tell a story. They're just characters in the story. They're not the story itself. There are other characters in the evaluation, including qualitative information, patient insights, expert opinion. And so the overall picture is made up of all of these different inputs, indicators being one of them. So I'm going to take you through a little bit of a trip down memory lane in terms of how measurement progressed in Canada in the evaluation of radiation therapy. So specifically looking at radiation treatment and trying to get a better sense of how effective is radiation treatment happening in the Canadian cancer treatment system. So this was back in 2009 when we developed a report, and in that report we looked at radiotherapy use. And the only thing we can do back in 2009, which is pretty sad, but that's what we could do, is look at the number of linear accelerators per 1,000 incident cases. So we reported on it by province, and you'll see that there's a range from the highest being PEI, 1.33, our smallest province, the lowest being Newfoundland at 0.86. And the average for Canada was 1.2 linacs per 1,000 cases. Very simple measure, lots of international comparators for it. And it didn't really cause any major revolutions, but it did cause a couple of provinces to take a look at their numbers. Alberta specifically decided to add 3 linear accelerators after our report in direct response to that, so we can raise our numbers. So it's a good thing. So starting with a simple measure is better than nothing at all. And something which is widely available, has some comparators, and you build from there. But that's not really evaluation. That's your first attempt at understanding what is going on for a specific topic, in this case, radiation therapy. So next year, we got a little bit more sophisticated. So we thought, now we're not going to look just at linear accelerators. We're going to look at courses of radiation therapy, because we could count them now. So this indicator now looked at courses of radiation therapy to new invasive incident cases. I don't know if there are any rad-oncs in the room here, but the rad-oncs in Canada had no idea what this meant. Like, it's interesting. What does it actually mean? Is high good? Is low good? Where is the ideal? How can I translate that to my own practice? So it caused a lot of confusion amongst the clinician community, understandably so, because it's an academic indicator. It doesn't really relate to actual practice. It's not relatable to the decision makers. So you have to measure what you intend to change, not just something that you happen to have some data for. So year after that, we got a little bit more smart and had better data. So now we're able to focus in on specific indications of radiation therapy. And so now we were able to look at rectal cancer, stage 2 and 3 rectal cancer, and looking at preoperative combined therapy chemoradiation, which is recommended by the guidelines. In this case, we're focusing on radiation only, whether chemo is provided or not. And we reported on that, and we had 5 provinces with data. And we saw there's variation. The good news here is that they're all going up between 2007 and 2008. The guideline was introduced in the sort of mid-2000s. So we're starting to see some uptake of that. If you're curious, by the way, BC here is we call this the penalty box, because their data was not comparable. So we decided to show them but show them in gray, just so you know what they look like. So these numbers showed that the average concordance with the guideline was less than 50%, so anywhere between sort of 35 and 45%. And so now we didn't have confused clinicians, but we had skeptical clinicians. So many of the rad oncs said, no way. I mean, I'm treating most of my patients with neoadjuvant combined therapy. These numbers can't be right. So we said, fine. So we went and we did a chart review. So our first objective was to validate the data. The data now, all of this information, I should say, is based on registry data. So we have quite a rich repository of routinely collected data on cancer in Canada. We have a national registry, which has all cancer cases. We have a registry of all hospitalization data, inpatient and day surgery, all admissions linked to the registry. We have data on radiation treatment that's done. It's all linked together. So we're able to use that data to calculate these indicators. Yet, chart reviews are the gold standard. So we did a chart review in 3 provinces. And we found that for 2 of them, the numbers from the chart review in the gray were actually pretty close, within margin of error of the data that we had. So we validated the numbers using the chart review results. And the chart reviews were done by oncologists, supported by trained nurses. So this was actually a clinician-driven chart review. And Newfoundland actually here found that there were some issues in the data. The chart review results were higher, and they were able to fix their data collection based on that. So that then put the minds at ease of the clinicians that, you know what, the data, the chart review is the gold standard. It's pretty much saying the same thing. We have lower rates than expected. But why is that the case? So then in the chart review, we looked at the detailed documentation around reasons for treatment or non-treatment, reasons for referral and non-referral. And what we found is that, for sure, less than 40% of patients there in the lower left slice of the pie were receiving preoperative radiation. We found that 27% were actually referred and received adjuvant, so post-operative radiation, which is not the guideline recommended therapy. The point of radiation therapy is to actually improve surgical outcomes because of the location and size of rectal tumors, and doing it afterwards still manages local recurrence, but it's not the recommended guideline. So a good chunk were getting post-operative, and 25% of the patients were referred but not treated with neither preoperative nor post-operative. Most of those were not seen by a radiation oncologist at all. So they actually did not have a multidisciplinary team consult. They were seen by a med-onc who decided not to refer for radiation. Others were patient choice, clinical decision, prior radiation, and so on. And then we found that 9% of cases were not referred at all by the surgeon. So the surgeon did the surgery and sent the patient home, no referral to an oncologist. So now we are actually able to tell the story of what is happening, and that then gives the evaluation a much more meaningful and useful dimension, because when you look at what's happening on the overall treatment pattern side, it tells you there's variation, but now you're able to actually explain what is going on. What you need to do is shift this slides over to this and ensure that there is a referral before surgery, ideally to a multidisciplinary team for assessment for preoperative combined therapy. And a lot of these documented reasons may not be valid. So that takes us to the point where we have something that we can actually engage clinicians on and get some changes in practice. So lesson is address the data quality doubts early on, and whenever appropriate, try and drill down on the detail to try and explain what's behind the numbers, because the numbers by themselves can be frustrating if you're not able to tell a story that explains why they are what they are and how they can be changed. So now I want to basically take you through a couple of examples of the next step of mobilizing the knowledge into action. So translating the measurement that we did into actual changes, and two types of changes. So system level changes are big changes to the way that the cancer system is designed and developed, where there's multiple sectors involved, multiple organizations. That's the hard stuff, the change that is much more challenging. And then individual clinical practice changes, which are like the example we saw in the preoperative radiation for rectal cancer, require a change in practice by a clinician. So more simple, more well-defined. Let's start with the hard one. So we did a whole sort of evaluation of breast cancer surgery across the country. And one of the indicators, we looked at breast-conserving therapy, we looked at mastectomies. One of the indicators we looked at is the use of day surgery versus inpatient mastectomies across the country. So we have very clear evidence that suggests that, that mastectomies can be performed on a day surgery basis with comparable outcomes to mastectomies with the proper supports for the patient, home care, and so on. And when we looked at the percentage of cases of mastectomy surgeries that were done on a day surgery basis across the country, we were surprised at how big the variation is. So Ontario and New Brunswick here were close to 40% of the mastectomies were being done as day surgery. And then you had other provinces like Saskatchewan and Alberta, less than 10%. Alberta, only 1.4% of their mastectomies done as day surgery. So now this is not about a surgeon making a decision. This is about a system being able to support a shift in modality, a shift in the way that patients are managed. So a more complicated change. And Alberta, which was our example of the province earlier that wanted to add the LINACs, also felt that they wanted to proceed with this. This is, remember I talked about going with the Coalition of the Willing, a couple of provinces who are interested in proceeding and then scaling that up. Well, they were the willing partner in this, and they wanted to make a change in their use of day surgery for mastectomies. So Alberta then launched an initiative and worked with them to develop this, to increase day surgery mastectomies. So they developed a provincial breast health initiative, and they had two objectives. One was to shift from mastectomy to breast-conserving therapy, so essentially increase their lumpectomy followed by radiation therapy treatment versus mastectomies. And the other was to increase the proportion of mastectomies done as day surgeries to 50%. Remember, they were at 1.4%, and they set a target of 50%. So they had a whole sort of multifaceted approach that we worked with them on. One involved developing a dashboard. The dashboard was available at the facility level that showed each hospital what its rate was by age and by comorbidity level. And they also showed the number of unscheduled ambulatory visits within 30 days of mastectomy. So for those day surgery cases, they looked at essentially readmissions or unscheduled outpatient visits as adverse events of day surgery. But they also implemented a number of enablers at the facility and community level because you had to, again, as I said, have multiple supports for day surgery, or our scheduling protocols were adjusted, discharge planning systems were modified, home care support was made available through the community health program for those women who were discharged from a day procedure. So all of these were in place, and then they measured progress. So Alberta went from the 1.6% in 2011, 2013, up to 34%, and then up to 40% day surgery rate in the first half of 2018-19. So significant, huge change in performance, again, based on what the numbers said and based on pretty significant effort led by the cancer agency there. So by next year, they should be at their target of 50%. And they also, this is an example of the dashboard or a screenshot of the dashboard that each hospital has available to them. It shows them where they are in terms of their actual mastectomy rate, but it says how many bed days are released, are made available now as a result. So each month, they get an update on the number of bed days released. And so in this case, 771 bed days were released as a result of the mastectomy shift. The breast conserving lumpectomy was at 83%, and they released 150 days. And the lymph node resection was at 73% day surgery, and they released 67 days. So you can see quite significant benefits in terms of opening up of inpatient capacity as a result. So that's another incentive for the hospitals to comply with the day surgery protocol. So now shifting to a practice, individual clinical practice change. This was the system level change, and now I'm going to talk about something that is, again, I'm going to focus on radiation oncologists. And so this is an evaluation that we did based on Choosing Wisely recommendations. So Choosing Wisely, for those of you who don't know, is a movement that was started by the American Medical Association working with Consumer Reports to identify interventions that were considered to be, questionable in value and potentially harmful to patients and should be avoided by clinicians. So there were 5 Choosing Wisely Canada recommendations in cancer. The first one is the one of interest to us, which is do not recommend more than a single fraction of radiation therapy for uncomplicated bone mets. So traditionally, patients with bone mets were treated with typically 4 or 5 fractions of radiation therapy in the past, and newer evidence suggested that a single fraction is as effective in managing the symptoms and is preferable for the patient because it reduces the number of visits to a cancer center and exposure to radiation. So a simple change in practice: don't order 5 fractions, order 1 fraction, and where the bone mets are uncomplicated and painful. So we measured this again for 5 provinces, and now we're looking at the percentage of patients who get multi-fractionation, not the single fraction. So the higher, the worse the performance. So we see Saskatchewan and Manitoba were examples of provinces that had close to 70% of their patients with bone mets being treated with more than 1 fraction of radiation therapy. And we sort of talked about the impact of what that means. So there were 11,000 patients who received multiple fractions of radiation to the bone every year. A 15% reduction, not 100% or 50, a 15% reduction in that could mean 1,500 patients avoid multi-fractionation, 2,000 hours of LINAC time would be released, and just under $1 million would be available for use for other healthcare services. That's just a 15% reduction. So that basically built the case for the change that we were looking for. Excuse me. So in this case, the coalition of the willing was Saskatchewan and Manitoba. They said, okay, we're willing to work with you guys, come in and let's see if we can change our practice patterns. So going back to our knowledge to action plan, we followed this very closely to work with our partners in Manitoba and Saskatchewan. First thing we did, so remember, measure is the first step, is we measured the practice at the individual radiation oncologist level. Because again, typically the clinicians you hear from when you provide indicators are the ones who are performing well, because they're the ones who look at the numbers and say, that doesn't make sense to me. I'm using single fractions all the time. Your numbers are wrong. Well, when we looked at the actual numbers, so each one of these lines is a radiation oncologist. There are 9 of them in Saskatchewan. And this is the use of single fractionation versus multi-fractionation. So the higher the percentage, the more multi-fractionation is done. So you see big differences. This is basically 2 centers, 2 cancer centers in a province of 2 million people. And you see it goes up from under 20% all the way up to close to 100%. So obviously a lot of variation. And then each clinician knows who they are in this chart and knows how they're practicing. And this was done over a 5-year period. So then we developed an intervention strategy to work with the rad-oncs. The first thing we did was we identified a champion from each province, and we intentionally did not pick the chief of radiation oncology in each province. We wanted a rank and file radiation oncologist who still had a lot of respect, a lot of credibility. And so we selected one from each province to kind of lead the intervention. We did roadshows through grand rounds across the 2 provinces. We did consensus meetings to agree on some of the definitions. What does complicated really mean? What are the conditions that would be amenable to a single fractionation-based approach? And so other definitional things so that rad-oncs feel comfortable that they understand what the guideline is and where it applies. And we did a couple other things, simple things. So we use automated order entry in Canada. And so when a radiation oncologist goes in to order the treatment for their patient, they have to select the number of fractions. All we did was we changed the default to a single fraction. And if they had to order more than one fraction, they had to actually justify it, pretty detailed justification. So that little change made a big difference because now it's just easier, single fraction, fine. I don't want to have to justify it. And then we did an audit and feedback on an individual clinician level so they can see how their ordering patterns change over time and the extent to which they're complying with the guideline. So we did a whole evaluation of the rad-oncs in both provinces, and the vast majority of them, their intervention increased the awareness of the recommendation, increased the knowledge of the evidence supporting the recommendation, and 100% of the rad-oncs in both provinces indicated a change in practice as a result of this intervention. So again, a very focused but selective way of making the case for changes in practice and behavior. So when you look at system level change, so our day surgery mastectomy, measure and set targets at the regional facility level, engage all players upstream and downstream. You have to make sure that everybody who's involved in that care pathway for a mastectomy case from the hospital into the community is involved, and be prepared for some system redesign and capacity adjustments to actually get all of the parts of the system in the right place for this to happen. Key to clinician level changes, to measure, report, and set targets at the clinician and facility. This is critical. If you're just reporting at a state level or national level, it's not going to be meaningful. Even a hospital level, you have to bring it down to the clinician level so they see themselves and see how they're contributing and how they compare. The message needs to be delivered by the physician or the peer. So if you're talking to rad-oncs, it has to be rad-oncs. If you're talking to a urologist, it has to be a urologist champion. So champions are necessary to drive to consensus, and then make it easier to comply with some simple things like the order entry default option in the example that I gave. So I know we need to leave time for questions, so I've got probably another 5-10 minutes. I'm going to talk to you a little bit about patient versus system-oriented performance measurement. It's the last piece of my presentation. And so I talked earlier about the importance of embedding the patient perspective in evaluation and measurement, and in a real and meaningful way, not tokenistic way. The first time we did that was when we produced a report on prostate cancer in Canada a couple of years ago. And so for the first time in this report, we recruited 50 prostate cancer survivors and patients. And we worked with them to develop the report and to interpret the results and to have their commentary on what it meant for them to basically have the kind of care that is represented in the evaluation and in the reports. So this is an example of a pattern of care indicator, and from the prostate report, this is looking at low-risk prostate cancer patients. So low risk is identified by pathological T-stage Gleason score and PSA. So patients whose tumors are non-aggressive, slow-growing, and who may not necessarily want to proceed with a prostatectomy or radiation therapy, but opt for active surveillance or watchful waiting, where they can be monitored on a regular basis to see if there is a change in the tumor growth patterns, and then make a decision at that point to treat or continue in active surveillance. So when we looked at this for 6 provinces, and this is looking at the percentage of patients with low-risk prostate cancer who are being treated with surgery, radiation, or combination. And we found big differences. Manitoba had the lowest, less than 10% of the low-risk prostate cancer patients were being treated. The rest were being placed on active surveillance. Nova Scotia was close to 50%. So the numbers are fine, but what does this actually mean? So how do you actually affect change in a way that is compelling in terms of its impact on patients? So in the report, we asked patients what they, the extent to which they felt that they were prepared to make informed decisions about their care. Did they understand the trade-off between risks and benefits? Were they given the opportunity to actually think about their options and make a decision that is consistent with their values, their quality of life considerations, what's important to them? And so those reflections were all intermingled with the results of the report in a way that really demonstrates the impact of this on patients. So this patient says, my experience was that I didn't learn about the side effects or anything until after the treatment. So I feel like I was cheated in some way, not being offered something up front before I got the treatments. And there were many, many patients who felt like that, saying if I knew that I was going to be, wearing a diaper for a couple of years or having my sexual function seriously affected, I would have been happy to live with a tumor inside of me. And others said, no, I knew what I was going into and I wanted the treatment. But the idea is to actually engage the patient and have them make a decision that's right for them. This report, so all of these reports, by the way, are available on our website, so systemperformance.ca. And this was one of the last reports we did, which was by far the most successful, we had the most feedback, positive feedback on this report from patient groups, from media, huge coverage, from the public in general. And there are many reasons, but one of the reasons is that this report was organized very differently from others. Instead of being prevention, screening, diagnosis, treatment, survivorship, palliative care, or even quality, sustainability, equity, we organized this report. We still had measures and indicators and other evaluation approaches, but we organized it in a way that is meaningful to patients, how they experience cancer. The first chapter was called Realizing Something is Wrong. And we concentrated our evaluation on that whole experience from the patient perspective and from the systems. The second chapter was called Hearing You Have Cancer. What was it like? So we still had wait times measures in terms of how long it takes from suspicion to diagnosis, but also what it meant for the patient to be waiting for that and hearing about it and whether they felt supported or not in that process. Being treated for cancer. We talked about decision-making and patient involvement in decisions. And then the last chapter was called Finding a New Normal. What happens after treatment ends? And patients go back or try and go back to their lives, dealing with multiple challenges, ongoing issues of fatigue, some pain, emotional distress, anxiety, practical issues, getting back to work, and getting coverage for some of the psychosocial supports that they need, and so on. So just organizing the evaluation in that way elicited a response that was beyond what we had seen before. And again, we're using the same kinds of measures, but nuanced and contextualized in a different way. So an example where we have patient stories, this is about being told about your cancer, where we actually surveyed what percentage of people were being told sensitively about their cancer and what it actually meant to them. Stephen saying the hardest part was telling my family and my friends about the diagnosis. Hearing it myself was easy. Telling others was the hardest part. We do patient-reported outcome measures for all our patients in Canada, and you can measure, the prevalence of fatigue and anxiety and pain and so on, which is, pretty high. So you know that, 23% of people feel moderate fatigue, 12% high intensity of fatigue. But then individual stories, Bonnie's and Charlotte's stories, tell you what that actually meant for them to try and get back into their lives and try and achieve this concept of a new normal. So the idea is that cancer is a human experience, and when you're evaluating it, it's important to evaluate it from a human perspective, from a perspective that is relevant to the people going through it. And so the pillars of a positive experience, the way that we've described them in this report, is I'm a unique individual, I'm respected, I'm empowered, and I'm supported. And with those pillars, then you're able to come up with a very meaningful and impactful way of assessing the extent to which you're delivering the cancer care that your patients deserve. So patient-centered last lesson is most compelling and impactful when the story of performance is told from the lens of the patient. Quantitative measures are balanced with qualitative perspectives and insights of patients and their family members. And again, the perspective of patients and family members is not tokenistic, but is an integral part of the assessing and evaluating the quality and performance of the system. Okay, thank you. Happy to take questions.
Any questions for Rami? People are warming up. While you're warming up, Rami, thank you. You speak with such logical cohesion that it makes implementing a data-driven quality improvement system easy. It was sobering to see your Delta process of 800 get down to 14 measures. And I particularly like that explicit focus on patients at the centre of everything that you do. The theme around seamlessness is a beautiful one. We all agree. You know, we've heard it described other things, no wrong door, etc. Can you give us an example off the top of your head of some indicators that might be monitored to demonstrate that it is a seamless system?
Absolutely. So one of the most frustrating and anxiety-ridden parts of the journey is that part from where there's either an abnormal finding or from a screening test or some other suspicious symptom that a patient presents. Between that time and the time of definitive diagnosis is one of the hardest periods. Measuring that pathway, that often circuitous, frustrating, confusing pathway. So how many touch points happened between the patient and their primary care doctor and diagnostic labs, imaging, until the definitive diagnosis. And oftentimes, actually, we mapped it out so that you can look at how many interactions and where they are in the city and how they bounced around multiple times until finally definitive diagnosis is there. So that gives you a sense of how tough and challenging it is from the patient's perspective. So we've started to look at diagnostic assessment units now, so one-stop shops for diagnostic cancer diagnosis aimed at specific cancers. We have them in place in Princess Margaret, Sunnybrook, a few other, and they make a big difference because it's one place, one lab, one clinic the patient goes to, and they know what to expect, they know how long they're waiting, and that makes a huge difference.
Thank you. There's a question on the back there. We'll bring the microphone to you. If you just tell us who you are and where you're from, that would be great.
I'm Helen Smart, and I lead the evaluation program for the Melbourne Genomic Type 9. I was really interested in what you spoke about in terms of individual clinician behaviour change and the importance of identifying the right champion. It's not the person who leads the program. Could you tell us a little bit, that's someone who's respected by the field. Could you tell us a little bit about the approaches you've used to identify best champion to drive key mobilisation and behaviour change?
Yeah, I don't know if there's this magic formula for doing that. We do have a lot of networks of various experts and clinicians. So we have a network of radiation oncologists, a quality radiotherapy network. So we have rad-oncs who sit on that network. We have the same thing with chemotherapy, medical oncology. We have the same thing with pathologists and so on. So often we recruit from those networks because they're already engaged with us. They're savvy about the numbers, about the data, about the evidence, but they still are very much close to the ground because we do recruit them again, mostly to be rank and file clinicians. So that's probably our most common way of finding the champions.
Rami, great presentation. I'd like to ask you about international benchmarking. What jumped out to me was when you showed the data on interventions for low-risk prostate cancer, that overall the percentages were very low. In other words, the active surveillance and watchful waiting rates were quite high. And maybe yes, we're interested in how that compares, internationally. So what do you think about international benchmarks as measures, and how meaningful are they, given differences in healthcare systems?
Good question, Greg. So there's been a lot of emphasis and work focused on international benchmarking in the last 7-8 years, starting with Concord and the ICBP as well. And they typically look at survival. And survival is the ultimate outcome measures for effective diagnosis and treatment. So the problem with them is that whereas they're a good starting point, they don't really tell you much about where the challenges are, unless you do some of that higher resolution analysis. So we have this ICBP project, which is essentially comparing a number of countries, similar universal health systems. So it compares Canada, UK, Denmark, Norway, Sweden, New Zealand, and Australia. And it showed Australia as having the highest survival rates in almost every one of the disease sites they looked at. So, and UK having the lowest survival rates in general. So that's helpful, but without really understanding the extent to which that's due to better early detection, better screening, better access to drugs, other therapies, faster access. We don't. It's an interesting starting point, and but if it doesn't get us to drill down and try and understand what's behind them, it's limited in usefulness. So it's not really the answer; it's the first question.
Mark was a medical oncologist. I look after brain cancer patients. In fact, a question coming, but our problem is not time to diagnosis, because that's usually a day or a second almost with the seizure. I have patients who are in the waiting room, knowing that their brain cancer is coming back, waiting to hear what their MRI scan shows. I find that a very difficult situation for the patients, I'm sure. And a lot of them are very anxious and worried. I got a scan a couple of days before or before. So similar problem, but different. My question is, given all of this sophisticated technique and learnings, and I wonder, have you had examples where, despite all intentions, despite all the lessons learned, despite you knowing that something should change, you've been hitting your head against the brick wall? And it's an example of something that you just haven't been able to change.
Yeah, it's a good question. The one thing you can change, so you may not be able to change capacity, the number of MRIs, the number of PETs in your system, or not change that quickly. The one thing I think that we can always change is the information that we provide to patients. And a lot of times, it's like when you're waiting at the airport at the gate and your flight time is long past and they don't tell you what's going on. You're just sitting there and waiting. If you only knew, if they tell you, you know what, it's going to be 2 hours. Yeah, it's frustrating, but at least now you know. So I think what we can all do better is to inform our patients, to make them more aware of what they can expect. And when they can understand what's happening, even though it may not be ideally what they want, I think that makes a big difference. So that's the one thing we can control the most. And I think that's the one thing that we all have a responsibility to do, is to make sure to keep our patients informed about what's happening and what's going to happen as much as possible.
Rami, Bob Thomas, I'll see you tomorrow, so I look forward to having a good talk with you. Fantastic presentation. Just a couple of points. Your first slide I loved, which was all little cogwheels, and we are afflicted with cogwheels in this country. So just one remark from you about how you make sure all the wheels turn in synchronous behaviour, if you like. I'd be grateful. The second thing I think is interesting is that despite the huge advances in health practices, I come back to your last slide, which is about patient experience. I'm sort of like an old fellow now, so what I get is people ringing me up all the time that they're going through all these wonderful experience of modern medicine, but they're having a terrible experience. And I think that for us to evaluate patient experience in a way which really puts it at the centre of our decision-making process is an important issue. So I'm wondering whether you have thought of using your administrative data sets to give you some idea about whether patients had a good experience or not.
So on the first question, the COGS, you're assuming they turn smoothly. They don't. Sometimes they don't turn at all. But so we have, at the partnership, we have very small carrots and no sticks, really. We have some funding. There's nothing that we can do in terms of, like the government can do nothing punitive. We can put data out there. The secret, I think, of the success we've had is that we are a network organization. So we work with networks of people on the ground in the provinces and territories, and everything we do with them, by them, through them, for them. So it's not that we're sitting on top devising a strategy to change the world and then unleashing it on the system. So that's my best answer in terms of the COGS. In terms of the patient experience, so we do use patient-reported experience measures, patient satisfaction surveys, patient-reported outcomes. The funny thing about patient experience measures is that typically cancer patients are just thrilled they're alive, and their satisfaction rates are always high because they're alive. So we end up with 92, 93, 94% positive satisfaction. It's when you drill below that, when you ask questions like, to what extent did you feel that you were well informed about what was happening? Or to what extent did you feel that you were given the chance to contribute to the decisions around your care? That's when you start to see some of the challenges. So I think, yes, patient satisfaction is important, but drilling down to the crux of the interaction, I think, is what's necessary.
Rami, thank you. I'm sure we could keep you here all afternoon, but luckily we've got you for another day and a half. But we've run out of time today. So thank you from all of us for coming and sharing your knowledge with us in Victoria today. Join me.